fellow Balance co-founder, Grant Craney, who will give you a quick overview of the network and how today's session will run. Over to you, Grant.
Thank you, Zainab. I hope everybody can hear me okay. So yeah, just to welcome you all to the webinar. We're really delighted that so many people could join today. It's fabulous to see. I'm going to just put a couple of things in the chat. One is the link to the Balance Cancer Network website, where you can register for updates and to potentially be part of the network should you be interested. The network's free to join, and any subsequent resources and webinars that we do from now on will be free. That's the aim of the network, is to try and make sure we're getting out to as many people as possible and sharing as much as we possibly can as well. So I'm just going to pop that in the chat now. If you have the time and would like to, then please check out the website. And the other thing is just to give us a little bit of a steer of where you're joining from. If you're able to pop in the chat where you're joining us from. And perhaps also what your specialist area is, whether that be in maxillofacial surgery, oncology, dentistry, public health, whatever. That'd be really interesting for us to know. So I'm going to just put in the chat for an example that I am Grant. I am dental public health is my specialty. And I'm in Glasgow, in particularly sunny Scotland just now, which is not normally the case. And then what we're going to, the kind of purposes of today, we're going to have an excellent talk from a very esteemed guest speaker, Eleana Stoufi, who's going to be speaking, which we're really delighted about. And we're going to come back at the end of the discussion, or end of the presentation, for a bit of an open discussion. So everybody is welcome to either post a question in the chat or the Q&A function, or also if you want to unmute your microphone and ask a question directly, then we would very much welcome that if you're able to as well. For the purposes of the presentation, if you could have your microphone off, that'd be really good, just in case there's a bit of background noise. And I'll just hand you back to Zainab at that. Thanks very much.
Thank you so much, Grant. Well, I guess let's get started. It's an absolute honor to welcome our speaker today, Dr. Eleana Stoufi. Eleana is a globally respected oral medicine specialist. She's a lecturer at Harvard School of Dental Medicine, and really someone who's been at the forefront of oral cancer prevention and tobacco control across continents. Her career spans clinical excellence, leadership in education from Harvard to Rwanda, from Greece's National Committee to international scientific bodies. She's not only shaped oral medicine training in medical schools, but also led nationwide campaigns against oral cancer screening and smoking cessation. With over 80 publications and hundreds of presentations and multiple leadership roles, she also brings her deep expertise and heart to this space. And I would like to say that on a personal note, having had the privilege of getting to know Eleana a little over the last few months, I can say that she's one of the most inspiring, humble, and generous person I've ever come across. She's deeply supportive of early career researchers, and we're so lucky to have her with us today. Over to you, Eleana.
Thank you very much for the introduction. You make me blush. Good day, everyone, wherever you are. I say good day, good morning here in Athens, Greece. We have a very sunny spring weather, but unfortunately I have bronchitis. That's why my voice is not that loud or clear. You will excuse me. I hope we can make it through the whole presentation. Thank you again, Balance, to start with, for inviting me. Thank you, Zainab, personally. Thank you, Grant, Hayal, Heather, for being there to try to start this seminar and make it happen. And I hope you can see my screen. Yes?
Not at the moment.
It just disappeared, Eleana. Sorry, it was up, but it's just gone.
What about now? No?
Maybe try sharing again.
What about now? No?
No, it was there, but it seemed to have disappeared.
Let me try again. Okay. Give me 1 minute.
Perfect. We can see it. We can see the screen now.
You do? Can you see it?
We
Yes.
can see it.
Okay.
If you
And
could
you can
do
hear
full
me?
screen. Yeah, we can
Yeah.
hear you.
All right. Let's see. Okay.
Perfect.
And you see
Perfect.
me and you hear me. Okay,
Perfect.
great.
Thank you.
We can.
So we're going to talk about oral cancer, early detection, and according not only to my opinion, it's a global imperative. This presentation, I aim to be short, so we have plenty of time to discuss afterwards, which I think is the most important part of our meeting today. Of course, I have no conflict of interest. And let's start so we get deep into the matter. According to Global Cancer Observatory in 2022, the incidence of oral cancer, including lip, is about 400,000 cases per year, and it was ranking number 16th. And regarding mortality, ranks 15th, and we have about half deaths, about 200,000 deaths per year. Regarding incidents, as you see here, if we add oropharynx into this category of oral cavity cancer, from ranking 16th goes up to 8th. So you see, it's a very common cancer regarding manifestation, but it's something that public doesn't really know, and that's one of the things we should aim towards. And as you see here, lip and oral cavity, as we said, is high above the manifestation ranking, right under lung, breast, but much above ovary, multiple myeloma, Hodgkin lymphoma, blood malignancies that people are aware of, but they are not aware of oral cancer. And again, when we get to mortality, the next table, again in 2022, we see that oral cavity mortality ranks relatively high. uh, Now, when we talk about European Union cases, we see that again in 2022 in European Union, we have about 40,000 new cases per year. And here Greece stands a little bit lower with 700 cases per year. And here I have to make a point that this number regarding Greece is a rough estimate. We don't have real numbers because unfortunately, so far we haven't got a national registry for cancer, and this is, of course, this is disappointing. But now it seems that we are starting having one, and I hope within a year or two we will have our own national registry for cancer. So this number you're seeing here, about 700 cases per year, is a rough estimate that we get from registries from neighboring countries. So before we address an enemy, in this case oral cancer, we have to know the profile of the enemy, in this case the disease. And this is my intention as an oral medicine specialist to address today as part of this presentation. So which are the malignant lesions of the oral cavity and what are their characteristics? They usually, mostly, they derive from epithelium. And we divide epithelium and surface epithelium, where uh, oral cancer derives in most of the cases, 19 to 95% of the cases are squamous cell carcinoma, and they manifest usually on the tongue, floor of the mouth, the lip, and it's the most common oral cancer worldwide. The second category is oral cancer of epithelial origin deriving from glandular epithelium, which comprises only 5%. And then it's followed by malignant lesions of pigmented tissue, less than 1%, mesenchymal origin, again less than 1%, and metastatic malignancies, 1 to 2%. The pigmented tissue lesions are malignant lesions are low because melanin or pigmented cells do not really exist in the oral cavity as they are in the skin. That's why we have low percentages. Now, one disappointing thing is that diagnosis of oral cancer carcinoma is usually late. Of those newly diagnosed individuals, only very slightly more than half will be alive in 5 years, approximately 55%. Early diagnosis has a 5-year survival rate higher than 90%, while late diagnosis only 50%. This shows how imperative need it is to do things to have early diagnosis of oral cancer, because when we diagnose our patients, usually they have metastasis, and over 50 to 6% of patients are diagnosed when they are on stage 3 and 4. So action has to be taken urgently to have an early diagnosis. And here I'd like to say one more thing. The oral cavity is an open cavity, so it should be easier and faster to diagnose oral cancer. We dentists or other fellow physicians inspect the oral cavity for our patients. The patients themselves have access to see what's going on in their mouth when they brush their teeth. It's not like, for example, a lesion on the lung. Unless it gives signs and symptoms, it cannot be inspected since it's not an open cavity. So we can see how disappointing it is not to have early diagnosis, and we will discuss which are the reasons and what could be done. So now, which are the high-risk groups? Individuals of an older age, here it says 30 years of age, it used to be older, over 40 or 50. Now the age has dropped to even 30s because we have a relatively new cause of oral cancer related, HPV viruses related to oral cancer or oral pre-malignant or potentially malignant disorders. Smokers. I will not talk a lot about smoking, besides saying that smoking and oral cancer as well as pre-malignant lesions are very tightly related. I like to say that smoking and oral cancer is like a person with his shadow. It's very highly related. 9 out of 10 patients with squamous cell carcinoma are smokers. But I won't get into detail because I think we will be planning a new webinar discussing tobacco products, older and new ones, and how hazardous they were, and they are regarding oral health. So another group is individuals who consume alcohol. The combination of smokers and individuals who consume alcohol makes the risk group even higher percentages of developing oral cancer. As I said, people who are positive for HPV, especially the type 16 and 18, which are mutagenic, immunosuppressed patients who develop a cancerization field, individuals with previous cancer, either of the site or other sites, metastatic ones, individuals, as I mentioned, with oral potentially malignant disorders or pre-malignant lesions. Most common ones is leukoplakia, which can develop to oral cancer if left untreated, and another group would be individuals with chronic trauma, poor oral hygiene, etc. Which are the mostly affected sites? Everywhere in the oral cavity, oral cancer might manifest, but most common sites are tongue, which represents almost 50% of the sites that oral cancers, especially squamous cell carcinoma, is presenting, especially the lateral borders and the ventral surface of the tongue. The lower lip, uh, where we have the sun radiation playing an important role in developing lower lip squamous cell carcinoma, and the floor of the mouth. Uh, Other sites in the oral cavity, like buccal mucosa, palate, and gingival and alveolar mucosa, might also be sites of oral cancer presentation. And here I want to make a point that I was aware very recently at another meeting we attended last month. Gingival oral cancer has been shown that it's getting more common, a more common manifestation, and yet we have not given a thorough explanation of why is it happening. One thought I've given, and maybe for our researchers here, that would be a nice clinical research or retrospective study, is the role of the new uh, tobacco products that they play in developing gingival cancer in these patients. And my thinking is all these new forms like electronic cigarette or even snus or tobacco might play a role in having oral cancer developing on gingival mucosa. That's food for thought. And I would be very happy to discuss it with you and maybe even participate with the research project. Now, what are the clinical features of squamous cell carcinoma? What should we or the public notice and be aware and be worried and try to figure out what's going on and seek for help? And we're mostly interested at the early stage presentation. It can present as a white plaque, as a combination of white and red, as a red plaque alone, as an erosion or a small ulceration that doesn't go away, or a small nodule, either it's ulcerated or not. Usually, that's the tricky part. Maybe one of the reasons we have late diagnosis is that the lesion, when it starts, is usually asymptomatic. There is no pain. So people think it couldn't be something wrong or something bad. They think that it might be trauma or something else, go away, and they wait, and they come and seek for help when it's probably late. And also, one other characteristic is it persists and has no tendency to heal. So for us, oral physicians, we should be very clear about that, and that's the standard golden rule. We oral medicines specialists say, if you see a lesion in the mouth that when you remove the causative agent, it doesn't go away, it doesn't heal within 10 or 15 days, have a biopsy performed. And always, when a patient comes with any lesion in the mouth, even if you make a diagnosis, ask for a follow-up after 10, 15 days to make sure that the lesion has gone away, or if it's still there, what further action should be taken. So here I have a few pictures of patients. These are pictures either of my patients or of my professor, Dr. George Laskaris, who is one of the most well-known oral medicine physicians in the world. And here are pictures of our patients at a very early stage. You see here a small ulceration on the lower lip, and this could be misdiagnosed as a trauma, a bite, or a secondary herpes infection know it is an oral cancer at a very early stage on the grounds of an actinic cheilitis, atrophic lip epithelium and skin. Another picture here, you see a small ulceration which is located at the lower part, at the apex maybe of this tooth, and it could be misdiagnosed as a fistula of a dead tooth and endodontically a dead tooth. But no, this patient had an early squamous cell carcinoma. And here I should say again, how precious a biopsy is, because sometimes with dentists we excavate the fistula, we remove what we think it's granular tissue. We never send it for a biopsy, and sometimes, like in this case, that was an oral cancer lesion. The patient lost valuable time. Here again, you see a small starting ulceration of the lateral border of the tongue. We could always say that maybe this edgy canine might cause a trauma. Same applies here. There are specific characteristics that might make us suspect that this is not just a trauma. Usually, when we have a trauma, the borders are soft because of the inflammatory tissue and the cells that get there to face the problem. While when we have oral cancer, the borders are indurated and hard because of the infiltration of the malignant cells. I don't know if I'm boring you with these details, but it's very essential to me to have a clear picture of how oral cancer presents at a very or can present at a very early stage. And here you see more ulcerative lesions at the ventral side of the tongue and the lower lip. Now, besides the ulcerative lesions, we can see that how it presents as a white lesion. It can be with distinct margins or diffuse margins. It can be white, dark, strongly white, which is what we call leukoplakia, looking like lesion. It can be white at the surrounding and ulcerated in the middle, like here. And this is one picture I like to present to my students when I teach. We have a big lesion. Here you see how big it is with different colors and texture. This is a very prominent leukoplakia, and this is also leukoplakia at the floor of the mouth. But if you look a little bit more carefully at the front, you see an erosion forming there, and this is where an oral cancer has already started developing. So it's very important to refer patients when you see them with such kind of lesions to an oral medicine specialist, so he can or she can evaluate the lesion maybe more properly. And it's very important the site we select to take the biopsy, because if you take it here, maybe the result will come back from the lab that it's a hyperkeratotic leukoplekic lesion, or again here another leukoplakia with no malignant features. But if you take the biopsy here, you will get the biopsy report saying that it's an infiltrating malignant squamous cell carcinoma, as you see here at the histopathologic picture. Red lesions can be together with white lesions or combined or alone. And here you see how they can present very mild, small lesions at the floor of the mouth or the ventral area of the tongue. This could seem very innocent, but this is a erythroplakia, which is a very quickly progressing malignancy, and it has a very bad prognosis. So it's very essential to diagnose it at a very, very early stage, and you see more lesions here and there. Again, as we said, it can also oral cancer can present also as a nodule, and you see here several ones at the top tip of the tongue, at the lateral border, on the gingival alveolar mucosa, here at the retromolar area. The three first ones are squamous cell carcinoma. This one is a Hodgkin lymphoma. So again, it's not enough to tell our patient how sorry we are if we made a late diagnosis, because the patient might be patient, but cancer is not. It's very important to diagnose oral squamous cell carcinoma, oral cancer at the very early stage. In advanced stages where I regret to say the battle has been lost in most of the cases, how it presents is a nasty deep ulcer with regular vegetative, maybe surface elevated, indurated edges. It can be exophytic or endophytic with varying degrees of induration. And of course, anyone who would see this kind of lesion in the oral cavity of a person, we would get worried, I guess, and know that something is not going right, and obviously would seek for help. But again, as I said, it's a bit late. So which are the prognostic factors for treatment? First, it's the location of the primary lesion. We know that lesions that present at the floor of the mouth or the lips or the tongue don't have such a good prognosis as the ones on the buccal mucosa, for example. Then another factor is the size of the lesion, the smaller the better. Whether there are cervical or distant metastases, understandably play a major role in the prognostic factors. New tumor characteristics that play a significant role again regarding prognosis and treatment is if there is growth development, is the growth development and the depth infiltration, whether we have perineural or perivascular infiltrations, then the prognosis is not as good. Of course, again, the histopathologic characteristics play a major role in the prognosis and the number of primary lesions. So, prognosis, as we said from the very beginning, is stage dependent. The 5-year survival when we have a diagnosis at stage 1 is over 90 to 95%. And this is literally as if we have patients free of disease if they are diagnosed at stage 1, while when we diagnose them at stage 4, the 5-year survival rate drops to 10 to 15%. Very disappointing. Usually, the patients we diagnose, the majority of them, is the diagnosis is made at stage 2 and 3, and that's where we have to take action and have an earlier diagnosis in favor of our patients. What needs to be done now? Which are the challenges and perspectives? The target we should all have is prevention and early diagnosis. So, which are the parameters for early diagnosis and prevention, of course? Public awareness is number one, and that's where we should all focus our efforts towards. Best treatment of oral cancer, as of oral cancers, is prevention. And one thing we can do about that is aware the public. There are studies that report an alarming lack of awareness about oral cancer symptoms and predisposing factors. We have to educate the public, our patients, one-to-one, but also in trying to communicate this with the public in general through other means like seminars, webinars, social media. We have to educate the public on eliminating tobacco consumption, the hazardous effects of tobacco on their health, moderation of alcohol intake. This is urgently needed to be done. Studies show that only 14% of the public is aware of oral cancer and its close relation to smoking. And I would like here to say again that we have the tobacco industry misleading the population now with the new products such as electronic cigarette, which they have produced, and they through marketing they declare that they are safer than combustion cigarette, which is a big lie. They are as dangerous as combustion cigarettes. So the public is misled, and we have to make clear to the public that this is not the case. Of course, we have uh, to educate, if you want, or dental professionals. The oral physicians, that's the term I like to use. I don't like to use the term dentist. We are not the physicians of the teeth. We are the physicians of the oral cavity. Our role is very important because we will probably be the first to encounter a precancerous or cancerous lesion. Therefore, we must have, and that's the reason I presented in detail the characteristics of oral cancer. We must have a very high index of suspicion and knowledge when we see an early lesion and have and do whatever we have to do, refer or make the final diagnosis of the patient. And of course, if we are not as general dentist able to handle the patient, we have to refer them to an oral medicine specialist, because second best treatment is early detection and early treatment of the lesion. Here are some of the actions that have to be taken, and this is uh, a table that we have used in Greece back in 2015. I had the privilege of being the scientific coordinator of a national wide campaign addressing both to dentists, oral physicians, and the public all over Greece. We did a campaign, and we addressed, as I said, to both dentists and public by uh, producing pamphlets, which we gave to the public through our dentists. We had them uh, in the waiting rooms of all dental offices, giving information about oral cancer. Also, we did a lot of many presentations to inform people about oral cancer, smoking, alcohol consumption. That was done with the collaboration of the dental associations of each municipality and the mayors of and the municipality of its place. And we had people, public, invited to attend these kind of presentations. Again, we confronted new lifestyle trends, and that's what we should do repeatedly. As I said, new products keep coming almost every day in the market. We produced a video with instructions of self-examination, which I intend to present right after this presentation, this PowerPoint. And also, we use TV and radio interviews to further aware people, public, about oral cancer. And nowadays, we should put in our hands and use social media, which is very popular, especially to the younger generation. And we should communicate all this information through social media with the public. Now, regarding the oral physicians, what actions we had taken and should be taken over and over again, as I said, we produced a handbook which was distributed to all dentists all over Greece, again giving detailed information from different aspects of view of oral cancer. We organized many scientific presentations again with predisposing factors, precancerous conditions, and oral cancer. We had them fill evaluation forms so we could afterwards evaluate how valuable that campaign was and if it was effective. And also we performed and we taught them how to do oral screenings, and we urged them to do oral screening to all their patients and not just treat the problem that they came practice to be faced. And here you see in Greek, of course, the material we produced. On the left on your screen, you see the pamphlet we produced for the public, and then on the right, it's the handbook for the dentists. So, what are the goals now we have to set, both in European Union but also globally? We have, I think, to design a common strategic plan to be applied to all countries. We have to join forces. We have to go to develop a strategic plan aiming the prevention and early detection of oral cancer. Secondary prevention, we have to aim there as well, regarding early diagnosis and treatment to reduce complications and costs, but also, of course, and mainly in favor of our patients. To emphasize the relation of smoking to oral cancer, it's mandatory to integrate oral cancer screening into healthcare systems. Screening into healthcare system is happening. Oral cancer screening should be incorporated, integrated into these screenings. And of course, use our associations, dental associations, federal associations of each country to work together towards those aims. You will tell me we know all that. Why don't we do them? Of course, money is the issue. Funding is fundamental and we lack sources. So we have to convince mainly governments that the above actions will not only save lives, but will also limit government costs because they will have less expenses uh, for treatment of an early cancer versus an advanced case. The care rehabilitation costs will be lower and there will be less loss of economic output. So we have to press governments toward that direction. And of course, our role is very essential. We have to embed policies in strengthening oral health services, and we have to provide tobacco cessation activities and oral health screening. And in order to do that effectively, we should all dental health practitioners be trained to educate, counsel, and treat or refer our patients. And of course, interprofessional training is also essential and very helpful. We have to work together, oral physicians, medical doctors, nurses, pharmacists. We have to do core curriculum training to medical and dental students. And here I am proud to say that in Greece, we have put the uh, tobacco hazardous effects as a seminar in our second year dental students, and they get educated about uh, the hazardous effects of tobacco in oral health, and they are encouraged to imply counseling uh, to their patients both in the school and afterwards when they do their own private practices. Of course, we have to do continuing education course training for all our colleagues. Closing, I would like to say that we have always to remember that teamwork is much more effective, and we should work not as a sole unit, but as a team with all our colleagues. Dentist is no longer treating teeth in patients. I want to strongly believe that, but rather we treat patients who have teeth. Thank you very much for your attendance, and I would like to close saying that all our efforts and our goals are directing towards the patients, our patients, who we have to benefit and do not harm, as Hippocrates said so many centuries ago. Thank you very much for attending, and I'm happy to answer any questions or start our conversation.
Thank you so much, Eleana. That was incredibly insightful and thought-provoking. Thanks so much to reflect on there. I would like to invite members of the participant, if they have questions, please jump in, introduce yourself. We want this to be a conversation, not just a talk. Sorry, Eleana.
Could I interrupt you? Would you like to present now the video we have produced during that campaign with the help of the Greek Ministry of Health and EU regarding the self-examination? Before
Yeah,
we start the
100%.
discussion?
Do you have the video, Eleana?
Yeah.
Okay, sure. Definitely. Go ahead.
Right now, let's just give me a minute.
Yeah, I wonder if anyone does have any questions.
We can
please,
do
you can
that.
pop your hand up, or you can pop them in the chat, and we'll read them out as well.
Yeah.
And I wonder if it's okay, Eleana, would it be possible for maybe us to go into some questions now?
We can go with questions.
We can maybe put
Here
the
it
video on
is.
at the end for people who are able to stay.
Maybe, I don't know, can you see it?
Yes.
Okay, it's just 2-3 minutes.
Perfect.
I'm sorry it's in Greek, but the picture will tell everything when you see it. As I said, it was produced by the Greek Ministry of Health, the Dental Greek Association, funded by EU. So here we guide our patient, how to do the oral screening, self-examination. We ask them to palpate, figure out if they have any nodules or lymph nodes detectable. How to examine their lips. How to examine the gums. How to examine the buccal mucosa. Here I have to say the fingers, they're not wearing gloves because they're the fingers of the patient. We make a point here that they have to examine the tongue all the way to the back and the floor of the mouth. So, and also we advise them to always visit their dentist.
Thank you, Eleana. It's really interesting because I think we've spoken in the past about how some colleagues here, in fact, one of the founding members of Balance, Niall McGoldrick, is looking into this and the feasibility in Scotland, and it's such an interesting thing where I was a practicing dentist for a number of years, and you would educate your patients on here's how you brush your teeth, here's how here's why you do it, here's how to eat healthier, but actually we don't show our patients, well, here's what normal looks like on your mucosa. Here's what a normal tongue or your tongue looks like. Then just now, if you see changes, then maybe to take notice of this, and you can let me know, or you can get in contact with us. So yeah, it's a really interesting avenue for trying to improve early detection. So thank you for sharing that video. I wonder if we'll take, there was a couple of questions in the chat. I wonder if we could just first go to our colleague who's got their hand raised. If you want me, just you can unmute and introduce yourself and ask your question. Is it Aristomenes? Aristomenes?
Can I say
Yes.
just a sentence here, if you may, if you allow me? I thanked at the beginning all the members of Balance, and you especially, but here I would like to say a big thank you to Dr. Stomanis Sigelakis and Maria Tsodidu, who are Greeks. They are very great colleagues of mine, and they are experts in oral public health. They hold several positions at the ministry. We've been working closely together. They have helped me a lot uh, in all these years that we work together towards the public good. And I would like to thank her in public for helping me because, as I said in the beginning, I'm an oral medicine specialist and they are my alter ego regarding public health. And maybe both of them can help me answering questions today. Thank you. I'm sorry for interrupting you, Grant.
Uh, Great. Thank you very much, Eleana, for these kind words. Actually, we are delighted of you, your work, and everybody in the conference, the recent conference of European Association of Dental Public Health in Crete, was inspiring from your lecture there during the special interest group. I very much liked your presentation. It is in a lot of levels. Even someone who knows nothing about oral cancer can find good information provided in the best way, but also some who are experts can recognize that the main points and the priorities you raise are very, very good. So I like very much also that you stressed out how important is community work, how important is interprofessional collaboration, and also I like the holistic approach you adopted from Hippocrates to the 21st century, and you close with Hippocrates. And this is the key. Yes, this is the key, the holistic approach for success. I would only like to stress out something. I think you mentioned that in one way, but I would also like to raise an ethical issue here. It is very important, as you said, the universal access to prevention. So that means at least organized prosymptomatic population screening programs for early detection and diagnosis, and of course all the primary prevention interventions. Yes. But think about this. I'm sure that you have already thought and you have the answer. We can find oral cancer or an oral precancerous lesion or condition, oral potential malignant diseases, as it is scientifically called. And if we don't have, as a health system, access to treatment, what is the ethical impact of that? What is the answer? We could detect it early and we could save your life, but no, we will not, because of the money or because health system is in favor of a few and not of a lot. And the second is how to stress out the importance of the interventions on social and commercial determinants of health. This is really very important because the role of diet, the role of employment, the role of living conditions, education, all this, as well as what the industry does to promote alcohol to promote smoking, etc., is we know how important it is. So this is all for what I want to say. Thank you very much once more. And I would like to have, if it is possible, an answer to this ethical issue I raised. Thank you so much.
Thank you very much for those really interesting questions. And you're quite right. Zainab and I come from a public health background as well, and they're very much at the forefront of a lot of discussions internationally at the moment. The way things that a lot of health systems are, and the way that the world and the way that they're being affected by what's happening. Eleana, I don't know if you have any initial responses to those questions, or if you want us to volunteer.
I would rather have you answer, but I can add a comment, or I think I spoke enough and should hear other people here. I read the comments on the chat column, and they are very interesting questions. And yeah,
we'll come to
one
them.
thing I would say is we have a very powerful tool in our hands, and this is people, the public. I think besides our efforts to work all together, and I encourage my colleagues who attend today's presentation to become members of Balance, so we become stronger. But I think we have a very powerful tool in our hands, and this is the public, the people. If go out and aware the people, what has to be done, and the difficulties we face from our governments, who are not very willing to fund this kind of efforts, maybe we will have a measure of pressure to the governments to give us more funding. That's one thing I would recommend or add to whatever actions we take towards that direction. And I think Maria Tsudeva would like to add something, and because we have discussed a lot of that about that, if you don't mind to give her Grant, sorry for interfering.
Please, no, I'm very welcome. Very welcome. Thank you very much, Maria. Thanks.
Thank you. Hello from me too. I'd like to congratulate all of you, your network, and of course the ABPH for this initiative. And as we all know, oral cancer is a growing public health issue with very serious complications. Eleana, thank you so much for mentioning me and my little help to you. You are an important scientist in the field, and I don't think I have gained from you much more than you have gained from me anyway. I'd like to make, let's say, a twist towards public health, or then that public health, with something I have to mention, maybe to ask from you. Do you have any data about how these determinants of oral health, oral cancer, sorry, the tobacco, the alcohol, the HPV infection, do they, let's say, do we find them more in some people, in some areas? Are there groups of people that are in more danger to have oral cancer than other people? And maybe related to their socioeconomic status or background?
Well, maybe you can help me in that question to get an answer. But what we know is that older people are more prone to oral cancer and those related with smoking, because as we know, cancer is a multifactorial disease nowadays, and it takes time to have mutagenic transformations from tobacco carcinogens. Also, we know that people who are HPV positive, they have maybe a higher risk of developing premalignant or oral cancer or genital cancer. We know it's number one cancer for women. Uterus cancer. So there is another point we should make very clear when we talk about prevention. Immunization of young children, both sexes, should be mandatory in our countries. So we protect them against those types that are producing cancer. I don't have any other data to present to you. Maybe someone can help me here. And of course, lower socioeconomic people, population is more prone to cancer because maybe they don't have they don't have regular checkups. They don't go to the physicians until it's needed. Here I could maybe tell you. Let me see. 40% of the American population they don't go to a physician unless they need to, which is a number very alarming, I think.
So you have answered my question. Older people and let's say people from deprived background are more prone to cancer. Yeah.
Thank you very much. Eleana, whilst you're looking at, I wonder if we just quickly go through the questions in the chat to make sure they get answered before, because we're really quickly running out of time. Thank you very much for the discussion. The first question from Mohammed is really in relation to a discrepancy between urban and rural, or people living in urban and rural areas, and actually that can have a big impact on time to diagnosis and the stage at which people are diagnosed, and whether the option of mobile dental clinics for screening or mobile screening is something that would be feasible.
That would be a very great idea, but again, the problem goes down to money. How can we to have those mobile units? How can we support them financially to go around to rural areas? That would be an excellent idea to be done.
And it goes back to what your colleague Aristomenes was saying about making sure the infrastructure is there. If you do diagnose, then what happens to those people? Thank you very much. And then a question from Nitu is about specifically with gingival cancers. You mentioned in your talk about the increased incidence, and perhaps is that down to certain forms of chewing tobacco or even some oral health products as a maybe a side effect of some of those? And is there any research as far as you're aware relating to that?
I would be very motivated to do a clinical research there. We can work with the colleagues in USA that they brought up this this issue last month when I attended that meeting, and maybe we could do a clinical study, even retrospective. That would be very interesting to me too. And I think that would be the take-home message. Let's not stay only to that presentation. Please feel free to contact me, whoever wants to exchange more ideas or have further discussion one-to-one or through another meeting or another session with any colleague who attended this presentation.
Thank you very much. I think in the interest of time, if people are able to stay on, then please do. Eleana, I think have you got 5 minutes to stay on to answer some of these questions with us?
Of course.
Which is really appreciated. The one in the chat from Danielle is maybe one that I can answer a little bit. And Danielle's a colleague of mine from the UK, where perhaps some of the evidence around public health interventions to improve early diagnosis, to improve oral cancer outcomes, is that there hasn't really been any great evidence to suggest that any of these initiatives have had a long-lasting, deep impact in improving outcomes for patients. And it's exactly right that some of these particular pieces of information, maybe at leaflets or maybe at specific, time-specific advertisement campaigns, actually do have limited evidence and outcomes. And this maybe reflects back to what we were talking about a little bit in our talk and in the discussion, is about knowing the population that you're actually targeting. And we're probably not as good I say we collectively as clinicians and researchers generally, at really understanding some of our target populations. And we're getting better evidence with oral cancers in particular about not only the specific disease-specific risk factors and behavioural risk factors and the demographics, but also about the health systems and the wider political and commercial infrastructure that exists. And perhaps this is a really good area for future work and trying to think about that for future outcomes. But it's a really big topic, and actually, it's probably a really good topic for us to look at in a future webinar or as part of Balance going forward, Daniel. So thanks very much for raising that. And a further question from Ghazal about is a really specific one about salivary biomarkers and biomarkers in general for deadly detection. And Eleana, that's something that you may well comment on. It's something that we are that's being investigated in some of the large interdisciplinary and multi-center studies being coordinated by IARC in France. Are doing some really interesting work into biomarkers for early detection or biomarkers to do with early and advanced stage disease, which is being done at the moment. So it's an area that we're looking at with great interest. I don't know, sorry, Eleana, if there's anything you wish to add to that.
Yeah, I am aware of those research protocols and projects. Of course, they're very helpful. Yes, there are biomarkers to detect early cancer. But again, here, I want to make a point. Not everywhere in the world biomarkers are available. We have to consider that not everyone is in a Western country or a country with a lot of funding. There are people who live in less privileged areas of the world that this cannot be the issue to use the biomarkers. Of course, I'm not saying that advances in medicine and research are in vain. Of course not. But I want to remind people and our colleagues that we have to remember public who lives in countries that's not available. And we are privileged, as I said, to have an open cavity. Why do you need a biomarker if you can inspect and palpate the mouth? Sometimes, at a very early stage, no lab exam will give you an answer, but only the clinical inspection and a biopsy. No MRI, no ultrasound, no CAT scan, no any elaborate lab test will give you a very early diagnosis as the oral examination, the screening, and maybe a biopsy. So yes, advances in science are very welcomed, but let's not forget the basic. And here I'm also waiting to see, anxious to see, thrilled to see the contribution of AI in our science. This is another big thing, which I hope I'll be still alive to see the progress, the application in clinic. I don't know if I've answered your question, but
Thank you very much, Eleana. That's great, and yeah, I'm sure you will be. But we look forward to seeing what that impact that has as well. In the interest of time, I'm going to bring the chat to the close, and just to thank everybody for the participation in that and for the questions, and thank you very much, Eleana and colleagues, for getting involved there. I've just popped in the chat again the link to the Balance Cancer Network website. If you wouldn't mind having a wee look at that, and if you're interested in receiving updates and perhaps joining what this is very much in the early stages of our international collaboration, then please register there and we'll be in touch. And I'm going to just bring it back to Zainab to close the webinar. Thanks very much.
Thank you so much, Grant. Thank you, everybody, for being here today, for having this rich, thought-provoking session. Huge thanks to Eleana, Grant, Heather at the back, who's been managing everything, and Niall, who couldn't be here but has been very instrumental in putting this all together. I just want to close by saying that this is exactly why we created the Balance Cancer Network. It's to spark these conversations and just remind each other that we're not alone in this work. So I hope that you will consider joining us, being part of this journey. We've got lots of exciting things coming ahead, more webinars with Eleana and other head and neck cancer experts. We've got in-person roadshows happening, and also planning to do some collaborative work together. So thank you so much, and hopefully see you in the next one.
Thank you. Bye-bye.